Okay. Good morning and good evening for all my friends from all over the world. Probably now you are in the daytime or in the night times. Please join our webinar today in ICC online. Today we are so honored to have Professor Jong-Woo Choi with us. Professor Choi has the MD and the PhD degrees. He is currently the professor at the Department of Plastic Reconstructive and Aesthetic Surgery at Asan Medical Center in Seoul, Korea. Professor Choi is majoring in cranial maxillofacial surgery and the microsurgical head and neck reconstruction. For the aesthetic plastic surgery, the orthodontic surgery and the rhinoplastic surgery are his specialties. Besides, he is focusing on the bone regeneration research and the 3D computer simulation and the 3D printing technology. Recently, Professor Choi leads the team to celebrate its 7,000 cases of cleft lip palate and the related surgery in Asan Medical Center. That is a huge achievement in the world. And in the past, I have learned a lot from Professor Choi in several international conferences, including ISCFS and AOCMF. So we are so honored to have the Professor Choi here with us today. The topic Professor Choi will share is very interesting. The management of the craniosynostosis based on his one-piece fronto-orbital advancement without Bandeau. So can't wait to listen and learn. Professor Choi, please.
Okay. Do you see my screen?
Yes.
Okay.
Yes.
Let's get started.
Please.
Good evening or good morning or good afternoon. So my name is Jong-Woo Choi from Asan Medical Center, Seoul, South Korea. You can call me JW Choi. First of all, it would be a huge honor to be a part of the Chang Craniofacial webinar today. So let me start my presentation entitled the one-piece fronto-orbital advancement without Bandeau using distractions. So actually I prepared two topics, but given the allocated time in 30 minutes, I think I will focus on only for one-piece fronto-orbital advancement concept. And actually, if the chances were allowed, I will make a presentation about the Looper 3 distraction using simultaneous direction will be presented next time. For the correction of the coronal craniosynostosis, the fronto-orbital advancement is known to be very necessary. So the supraorbital osteotomy with the frontal bar in tongue groove fashion, suggested by the Dr. Tessier, has been a long-time standard in craniofacial surgery. Still, many the European and US doctors prefer this traditional technique because it is known to be very safe and it is very good not to injure the dura mater. However, so sometimes, although I prefer my technique, but when I encounter these kind of complex type of the craniofacial morphology, I still use the traditional fronto-orbital advancement suggested by the Tessier, like this. In a tongue groove fashion, actually making a Bandeau, then the fronto-orbital bone flap was reattached to the dura. Actually, it works quite well. But isn't there any other alternatives? Let's get started with the one-piece cranial distraction without Bandeau. So in early 2000, actually some Asian craniofacial surgeon, such as the Kaneshige Sato or Yong-Woo Kim, who is my mentor, and then Dr. Imai suggested the distraction technique for the correction of the And Imai, although he applied the fronto-orbital advancement with distraction, but at the time he used a huge bony block resection like this. Actually, my journey for the craniofacial surgery, including the simulation surgery, began with my mentor, Jong-Woo Kim, who is one of the good friends with Dr. Langelo here. This is his previous design in early 2000s. At the time, he used the temporal bony block resection, and then the osteotomy line is like this. And then after the distraction, you can see some changes. Actually, he made multiple publications regarding the application of distraction in craniosynostosis. In addition, he developed custom-made distractor for the cranial facial surgery. But in early 2000, as a junior professor, I was already reluctant to apply the distraction in my practice. So I followed the Tessier's principle, making a Bandeau and then two bone flap was made. And then it was separated from the dura and then reapplied on the craniofacial part. Then I applied the distractor. Actually, it works in the long term. However, I experienced some relapse in some patients, so I started to think on other alternatives, on some modifications. One question came up to me. Are we maximizing the potency of the distraction? Are we sacrificing the benefit of distraction? One-piece fronto-orbital advancement without Bandeau was my answer. Since 2005, I started to apply this technique in my practice. In 2009, I published my first paper entitled One-Piece Fronto-orbital Advancement with Distraction, but without supraorbital bar for coronal craniosynostosis. Is the Bandeau mandatory requisite? Should we detach the frontal bone flap from the dura like the traditional technique? So this is my technique. Without making any Bandeau, then actually I focused on the pterion parts, which would be the thickest part for the detach. Actually, 3D printing turned out to be very helpful to identify the pterion location. I thought if I could detach or dislocate the pterion parts, without detaching from the dura mater, the frontal bone distraction could be possible. In more details, if you see, the pterion consists of lesser wing of the sphenoid, A, the greater wing of the sphenoid, B, and C is the temporal bone and the frontal bone. So after making a small bore hole, 1 cm or 1.5 centimeters, then I do an osteotomy without detaching frontal bone flap from the dura. So 2005, this is my first case at the time, without making any Bandeau and without detaching the bone flap from the dura, I could distract the frontal orbital parts like this. So I was thrilled. 30 months after, then I do the lupus 3 midface distraction, before and after, at the age of 6. Another example of one-piece fronto-orbital advancement without making any Bandeau, I only made osteotomy circumferentially, including the supraorbital, the bone area. Before and after, you can see how much I distract the frontal bone parts in the long term. Another case, the brachycephaly. So 1.5 centimeters at the time, 2006, I made a little bigger hole here. 2007, actually, I tried to a smaller bore hole on the pterion area. Actually, it works. Actually, this is a more recent case, the unilateral coronal craniosynostosis. You can see some harlequin sign and the asymmetric forehead here. So this is the complete the circumferential osteotome without making a Bandeau, without detaching the frontal bone from the dura. And then this is the 2 distractor on one side to control the vector of the bone flap. And then the other side, because this patient is a plagiocephaly, sometimes I use the wire or sometimes I use a biodegradable plate. So this is before. And then after the osteotome, as you see, I didn't make any Bandeau here. Then in the long term, Harlequin sign was corrected naturally. Another bilateral coronal craniosynostosis. As you see, I didn't make any Bandeau. I make a osteotome circumferentially before. And then this is my osteotome. And then this is my boho on the Therian, actually much smaller than Dr. Imai or my teacher, Jong-Woo Kim. So actually, I found out 1 cm boho would be enough in the long after the distraction. Compared to the traditional remodeling surgery or bone repositioning technique, actually bone defect turned out to be much, much smaller because I didn't detach the frontal bone, and then distraction could allow us to get more solid bony regeneration. But another question aroused me again. Is minimal invasiveness only an advantage of distraction in craniosynostosis correction? Isn't there another benefit when we apply the distraction technique onto craniosynostosis? This was my second answer. In 2010, I published this article in PRS entitled Endocranial Correction Using the One-Piece Fronto-orbital Advancement without Bandeau in Unilateral Coronal Craniosynostosis. Different from the positional plagiocephaly, craniosynostotic patients always was accompanied by the skull basis anterior posterior angulation like this. The Jeffrey Marsh in 2003 in PRS, he mentioned the skull base axis angulation of the anterior and posterior cranial fossa would be a crucial factor in symmetric craniofacial growth, including the face. Actually, I investigate the outcome of the traditional technique, bone repositioning technique, performed by previous professor. So after the remodeling surgery, actually skull base axis wasn't corrected well. Quite similar. This is the bone repositioning technique outcome. Skull basis angulation was not corrected well, in spite of the frontal bone restoration. In 2003, this patient underwent the cranial bone repositioning technique, but because of IICP, I had to do another fronto-orbital advancement. And after the distraction, I found out the skull basis angulation was corrected like this, accidentally. So I started to apply and focus on the skull basis angulation. Before and after the distraction, the skull basis angulation between the anterior and posterior cranial fossa was corrected. I could get really consistent result in every patient. Actually, in these patients, the distraction amount was not enough, but overall, I could get decent result. Another, I couldn't do much distraction, so Harlequin sign still remains. So I tried to do the more distraction until we get the skull base straightening. So before and after, the Harlequin sign was corrected spontaneously like this. So this is my technique. So one-piece fronto-orbital advancement, and then distractor were applied unilaterally, while fixating the pivot point with the wire. So compared to the traditional technique, the distraction technique revealed us that the skull basis angulation correction would be much more superior. Another question, when would be the best timing for endocranial morphological changes? So this is my paper in 2017, comparison of the endocranial morphology according to age in one-piece fronto-orbital advancement using distraction in craniosynostotic plagiocephaly. So I categorize the patient group into two, under 1 year and over 1 year. Overall, the conclusion was the earlier, the better. Probably the remodeling, the capacity of the infant may influence these kind of results. Another question, are the results of the one-piece technique and endocranial morphologic change maintained in the long term? So I analyzed the long-term surgical outcomes based on the review of 26 consecutive cases. The result over the 8 years follow-up, skull basis angulation correction was maintained very well. Then cephalic index was maintained quite well. Probably we corrected the fundamental, the etiology in earlier ages. I'm not sure what kind of mechanism may affect this kind of result. Probably the tension force during the distraction on the skull base may influence this kind of outcome. Possible mechanisms include the distraction of spheno-frontal suture area or modification of the functional matrix or remodeling capacity of the endochondral bone on the skull base. I will show you my short video clip related to the one-piece frontal advancement without Bandeau. Before the surgery, in order to minimize any dura mater damages, neurosurgeon, pediatric neurosurgeon, my partner, always do the lumbar puncture to lower the intracranial pressure. Actually, it is very helpful not to injure the dura. And then bicoronal incision, I prefer the zigzag incision to minimize the scarring. And actually the dissection would be similar. And then on the terion area, I making a point for the terion area, which would be the thickest part. And then this is a plagiocephaly, so some bony resection will be done to overcome the contralateral frontal bossing. Then I dissect intracranially. Then sometimes we insert the cottonoid or some baseline gauze to protect the dura during when we do the suprabar, the osteotomy, the dura mater injury could be possible. In order to minimize any kind of problem, so using the small Lindemann bore, I made a small group along the supraorbital osteotomy line. Then I used the small, sometimes this is actually a little bigger osteotome. Usually I use the 2 or 3 millimeters small osteotome for the osteotome of the supraorbital bar. Like this. Then after the making an osteotome like this, you can feel the complete movement of the bone flap. Like this, you can see the movement of the bone flap. If you do a complete circumferential osteotome, you will be able to feel the complete movement of the frontal bone flap. Then this is the wiring procedure for the pivot point. Then I'm applying the distractor. Although my mentor Jong-Woo Kim usually used the 1 distractor, I prefer at least a 2 distractor, control the vector of the frontal bone flap, depending the patient, the situation. So as you see, I didn't make any Bandeau, so circumferential osteotomy was done. Actually, the technique looks simple, but not to injure the dura would be the most crucial part. But based on my more than the 80 cases of the fronto-orbital advancement without Bandeau for last 15 years, actually, I didn't experience major complications. In summary, the one-piece fronto-orbital advancement without Bandeau turned out to be possible without complications, and it can change the endocranial morphology and endocranial morphology encephalic index. So another modification based on the one-piece fronto-orbital advancement without Bandeau for the metopic craniosynostosis. So can we use the distraction technique for the correction of the metopic craniosynostosis? This is the conventional bone repositioning technique. Actually, it could correct the trigonocephalic feature to the round type. Yeah, it works. However, what I was satisfied with the conventional surgical outcomes, actually frontal bone advancement was not enough. So in this case, I made a one-piece fronto-orbital advance, and then I do a midline splitting osteotome for the correction of trigonocephalic features. Before and after, trigonocephalic feature was corrected using the one-piece technique. Another case, 2017. At the time, we resected a little larger bony block, more consolidation than after the distraction. Another case, one-piece distraction accompanied by midline, the splitting before and after. What I do like, what I prefer is the actually frontal bone advancement was the amount of the frontal bone advancement much larger than the conventional surgical techniques. So for the details, you can refer to my articles. As you see, based on the one-piece fronto-orbital technique, I added one osteotome on the midline for the correction of metopic sutures. What about the midface morphology after the one-piece fronto-orbital advancement in unilateral coronal craniosynostosis in the long term? Actually, this is my almost finishing ongoing study, midface morphology in one-piece fronto-orbital advancement without Bandeau. So this is unoperated unilateral coronal craniosynostosis in adult age. Actually, probably Jong-Woo may experience many patients like this. Unoperated patient was accompanied by the twisted midface, but also the orbital dystopia like this. Actually, using the Tujo surgery or somatic surgery, actually correction of the asymmetry would be very challenging because the level is not the same. In skull base in this patient, actually skull base angulation exists. This is what I call twisted face. As you see, the pterion area, the level or height would be quite different from the compared to the contralateral side in unilateral coronal craniosynostosis. So we investigate and measure the various landmarks related to the endocranial morphology and the midface. So after the distraction in the long term, overall, the level was similar. This is a 10-year follow-up patients. Unilateral coronal craniosynostosis was corrected using the conventional bone repositioning technique by my previous professor. But because of IICP, we had to do a distraction again before and after the orbital harlequin sign was corrected in the long term, 10-year follow-up. Skull base morphology has corrected like this, not perfect, but much better. So this is the before and after the traditional bone repositioning technique. Then this is the after the distraction, and then 5 years and 10 years follow-up. Overall, not perfect, but midface, the twisting could be minimized, not perfectly, but acceptable. These patients underwent the previous endoscopic suturectomy in other institutions, but because of the not perfect symmetry, the patient visit our institution. More complicated cases for the one-piece fronto-orbital advancement. So at the time we applied the same technique, then we distract the posterior parts, these. Then in the long term, 6-year follow-up. The skull base axis angulation was corrected, orbital dystopia corrected after the distraction in the long term. So I don't have enough time for the details. Is overall, the midface and the endocrinal morphology could be minimized. This morphology could be minimized using the one-piece fronto-orbital distraction. Finally, I will make a mention about my application of 3D computer simulation for craniofacial distraction. In 2000s, mostly I depends on the 3D printing tactile model for the modeling. But since 2014, I started to apply the 3D computer simulation for the craniosynostosis. So I developed 3 parameters, such as the 3D craniometric evaluation, which could be used for the measurement of the metopic or the coronal, and 3D volumetric parameter also developed, total intracranial volume and segmental intracranial volume, and 3D morphologic parameter were developed. So this is one example. One-piece fronto-orbital advancement was done. Then overall, the color has been changed. We can quantify the surgical outcome using this 3D model. Metopic Craniosynostosis was corrected using the one-piece. Then, as you see, the convex, the red midline was evenly distributed post-operatively like this. We can quantify the surgical outcome as well in this case. In summary, 3D computer simulation for craniofacial distraction allows us to plan the more precise osteotomy, and it allows me to measure the surgical outcome more objectively. For the details, you can refer to my article in 2019. In summary, one-piece fronto-orbital advancement without Bandeau works quite well. In my practice, I strongly believe, without minimal complication. It turned out to be very helpful for the bony regeneration. It could change the endocrine, not only the endocrinal morphology, but also the midface morphology. Metopic craniosynostosis on the midline osteotome were beneficial for the fronto-orbital advancement. And finally, 3D computer simulation turned out to be very beneficial and necessary for precise craniofacial distraction. In conclusion, the one-piece fronto-orbital advancement without Bandeau turned out to be possible and helpful for correcting the endocranial and midfacial dysmorphology in the long term. Thank you so much for your attention.
Thank you, Professor Choi, for your very impressive and question by question, step by step to get your final answer. Yeah, I thought a lot of very long-term, very good outcome in your series. I think in the first of all, we have a lot of participants in our webinar tonight. So I would like to invite Professor Tin Chen. Yeah, Tin Chen is currently our expert in craniosynostosis treatment in Chang. So please invite Professor Lu to give us some comment for Professor Choi, please.
Hi, Dr. Choi. I think that's a very excellent result. So I have few questions. The first one is, what is the endpoint of the distraction? Like the brachycephaly, I saw on your screen said it's like 25 millimeter, and for the unicoronal, it's like 32 millimeter. So how do you decide the endpoint of the distractor?
Yeah, really good question, Dr. Lu. Actually, the benefit of the distraction would include the surgeon could make a decision in endpoint, actually in outpatient clinic. So we have much more time to make a decision in terms of endpoint. So actually, my pediatric neurosurgeon and I developed, custom-made the cranial distractor, and then actually maximum distraction amount is 40 millimeters. So, but actually mostly 20 or 30 millimeters in our practice. It depends on the situation, but if I see if I obtain the symmetry, I end the distraction. It depends on the situation. Sometimes I use the CT scan or the simple skull X-ray. But as a plastic surgeon, actually, I believe my eyes. Yeah, sometimes I had to depend on the X-ray or CT scan, but mostly decision would be made based on my subjective morphologic evaluation.
Great. So like for the unicoronal cases, some surgeons suggest to do overcorrection. So do you do overcorrection for those cases?
So different from the mandibular distraction, I think the cranial distraction looks really, really stable because of the blood supply of the dura mater, and then the bony regeneration is really, really fast. So I think the relapse, actually, according to my investigation in several papers, actually, relapse ratio would be really, really minimal. But the problem is we cannot discriminate the relapse versus the growth. So that would be the tricky part. But mostly I do not do the overcorrection in craniofacial surgery. But sometimes I encounter the too much distraction, so too much the protruding forehead, because the patient didn't come, and then 3 weeks after, too much distraction. So I was so surprised. Sometimes you may encounter that kind of patient. So actually, reverse distraction didn't work well. So I see the patient, but after the patient grow, so it looks naturally change it in many cases. So, but generally speaking, I don't prefer the overcorrection, especially in craniofacial, the cranial distraction.
Yeah, okay, thank you. So the other question is, what is the age you prefer to do the distraction?
So yeah, so mostly the earlier the better. That's my belief. But different from the Western society, I think Asian patients tends to come and visit the medical center quite a late period, after the 6 months. And then because I think in coronal craniosynostosis, actually compared to the Western people, we had a little brachycephalic features. So actually the parents doesn't care about that. But 6 months after, if for evident, so patient comes. So if the patient comes after the 6 months, we are trying to do earlier surgery. But before the 3 months, actually, my pediatric neurosurgeon are reluctant to the distraction because the bone is too malleable, too soft. So may distraction to make any deformity. So actually, mostly earlier the better. But most patients is from 6 months to 12 months.
Okay. So the other question is, do you like free the dura like 1 or 2 millimeter around the osteotomy site, or you just cut the bone and you don't free any dura?
Yeah, so as I show you in my video clip, so if we could, I try to dissect the dura along the osteotomy, especially the supraorbital bone area,
Mhm.
and I inserted some cottonoid, and then the osteotome would be much more comfortable. But sometimes it's not that easy because of severe adhesion. I don't know why, but at the time I used a small bore hole, and then I didn't do the complete osteotome. But after the circumferential osteotome, you can use the freer dissector, and you can insert very smooth, and then you can check the complete osteotome. So if you make any the um, in continuity, and then you can focus on the osteotome at that part. So that's my surgical tips for that.
Okay, thank you very much.
Yeah.
Okay, Professor Choi, yeah, I have one question because you apply two different vectors of the distractor. So as you experience, how do you judge the different vector to do the distraction, how the rate, and how do you judge the different strategy for adjustment? Thank you.
Yeah, so actually patient has a really diverse the morphology on the frontal the area. So I call the temporal distractor, we call it. Temporal distractor mostly in charge of the frontal, the Bandeau advancement, and then the parietal distractor, the 45-degree area, while avoiding the sagittal sinus. Actually, I really concerned about sagittal sinus damage, so it would be disaster. So always I apply the distractor in the beyond the sagittal sinus. And then these parietal distractor are in charge of the angle of the forehead. So the patient has a flat and then protruded the forehead. The temporal distractor has a mole distraction like this. So you can have a mole, round the forehead, and then the patient has already the protruding forehead. So I will only do a temporal distraction like this. But I think always I try to the 4 distractor for bilateral and 2 distractor in unilateral.
Okay, and I'm so curious about metopic cases. For the metopic cases, you apply 4 distractor, yeah, and in the middle you do the osteotomy. So how do you to prevent the middle side to protrude anymore and to encourage the bilateral lateral side to more protrude?
Yeah, so I didn't have the time for the details, but I usually use the wire here.
Okay.
Wire here. So if you want to a little more fronto-orbital advancement, a little loose wiring. So we can control the amount of the frontal bone flap, the advancement. So if you tight the wiring, so it will have a like this and then like this. But if you have a loose the wire, so it will have a advancement first and then like this. But actually, it depends on I didn't find the complete perfect answer for that. So most cases looks okay, but I'm not satisfied with my result perfectly. So I'm still trying to find out the ideal way for the correction of metopic synostosis.
Okay, thank you, Professor Choi. I have one final question. Would you do this kind of surgery in just the pure plagiocephaly cases? Yeah.
So sorry again.
Just apply the surgery on the only plagiocephaly cases, no synostosis.
Not craniosynostosis?
No craniosynostosis.
Oh yeah. So actually, my mentor Jong-Woo Kim used to be really expert in the handmade molding therapy. So yeah, he developed his own company, and then I'm using the Starband and his company's the hematherapy. So hematherapy is my answer for the non-craniosynostic plagiocephaly, but mostly some pediatric neurosurgeons are still using the endoscopic suturectomy and helmet therapy.
Yes.
So ISCF members actually are really, really enjoying that kind of modality. But according to my experience, actually, sometimes we didn't get the satisfactory result based on the molding therapy followed accompanied by the endoscopic suturectomy. So we prefer the surgery, but sometimes we do the endoscopic suturectomy and helmet therapy. Yeah.
Okay, thank you, Professor Choi. Thank you again. And later I invited Professor Lunzo Low to give us the comment. Thank you, please, Professor Low.
Hi, Jong-Woo. Very
Yeah.
nice to hear you talk. Really appreciate that your enthusiasm in doing this operation and your idea of doing the so-called the whole piece without a Bandeau and do the advancement. It's a good operation. Just curious, you do that so-called the sub-ostial underline the bone, the dissection between the bone and dura by yourself or with the neurosurgeon?
Yeah, by the pediatric neurosurgeon. So
Okay.
sometimes I do, yeah. But as a surgeon, I always think, yeah, if I can manage the complications, I can do. But I can do the osteotomy. But if I cannot deal with the complications, I think we should not do. So actually,
Okay.
my mentor Jong-Woo Kim do by himself. You know, you are the best friends of him. Yeah. So, but Jong-Woo Kim actually recently has the health problem. So I hope he will be able to recover soon. But yeah, different from my mentor, actually, I'm more comfortable when my pediatric neurosurgeon do the osteotomy, on the coronal parts. Yeah. The other
and
parts,
also I enjoyed that you also pay attention to the endocranial morphology. That the unicoronal synostosis, you have the angulation of the endocranial base. Actually, that paper was by me. When I was 1993, when I was with Jeffrey Marsh, we
yeah,
did that
I heard.
operation. That really is a good paper. That,
Yeah.
but not many surgeons pay attention to the endocranial base. They only pay attention to the so-called external appearance. So appreciate your point of that endocranial correction. So overall, I enjoy your talk. You're really a good surgeon. Congratulations.
Thank you so much, sir. But without the previous research and the mentor Jong-Woo Kim's research, actually you spent this similar in period with the Jeffrey Marsh, right?
Yeah.
Yeah. So, but I didn't know that paper was was by yours. So yeah, I finally found out the origin. So yeah, I'm really happy. Yeah, so I'm really interested in actually, as a plastic surgeon, we need to consider more about that, especially in facial asymmetry correction.
Maybe you can also comment on that there are many different approach to craniosynostosis. If you look at the literature, we can see total remodeling one time, or with destruction, or with strip craniectomy, endoscopic. And what is your idea behind doing this destruction? I really saw your good result, but maybe for the young surgeon, if you look at textbook, there are so many different approach. Can you comment on this?
Yeah, so still I'm doing the total calvarial reconstruction in very complex type, but I saw the many long-term surgical outcomes performed by senior professor in 1990s based on the total calvarial bone reconstruction. So many cases showed us the amount of advancement was really limited, and then very flat forehead, like a tension band, the deformity is not that rare. So, and then because we are dealing with really young patients, tissue. So I think if it were possible, the minimal approach would be better in the long term in terms of the growth. But I don't know the definite answer. But as a surgeon, we have to know all the modality, including the total calvarial bone reconstruction and endoscopic suturectomy. But endoscopic suturectomy mostly done by the pediatric neurosurgeon. He does not consult the patient at all. So actually, I don't know the surgical outcomes. So actually, I have a limited the exposure to the pediatric neurosurgeons, the surgical outcomes. So if we collaborate with the pediatric neurosurgeon more, it would be better.
Yeah. Okay. I also have another question that when we do Litho 3 destruction, Litho 1 destruction, the maxilla usually stop at that place without further forward growth if you follow the patient at a long time. Okay, so that's why for Litho 3 destruction, Litho 1 destruction, we tend to do overcorrection.
Yeah.
Okay, I don't know how about the cranial part. That's why Dr. Jinchen Lu, she asked whether you do overcorrection. I also recently read some report like unicronosynostosis. You need to do overcorrection anteriorly or laterally. Since you also follow patient long term, what is your observation? Do you see continued growth, or you destruct at this level and it stop growing from this level? What is your observation?
Yeah. So actually, I wrote the that issues with the Jong-Woo Kim. So cranial growth after the distraction. So
Yes.
actually, that would be one answer, but different from maxilla and mandible, the maximum potency of the cranial growth, the range growth ranges from 2 years to 4 or 5 years. So maxilla growth would be the maximum, the potency ranges probably in puberty and then after the 10 years. So in that age, actually, I don't do much overcorrection after the overcorrection in cranial distraction, but I always try to do overcorrection maxilla and mandible as you do. Yeah.
So you mean that in the cranial part you observe further growth after the destruction?
Yeah, the paper say
Continue growth.
the continuous growth could be possible even after the distraction.
Okay.
Yeah.
Thank you very much. And also, please say hello to Jong-Woo Kim, and I wish him well. Okay.
Yeah.
Recover
He's
soon.
getting much better and better. Yeah.
Okay. Yeah.
Yeah.
Thank you.
Yeah.
Okay, thank you, Professor Choi. We have several questions from our audience that we want to ask you. The first question is, do you use distractors for sagittal craniosynostosis?
Yeah, actually, I didn't mention about the sagittal synostosis, but in 2000, or the late 2000, we mostly use the reverse distraction, the contraction type for the like a pie surgery, because the patients they visit our institution in really late period, And then if the patients allow us to do, and then the sagittal distraction was done, but compared to the coronal craniosynostosis, the bilateral, the transverse distraction for the sagittal sinus has some problems actually, because we had to make the osteotome on the temporal line, and then these parts distraction, the morphology is not that ideal. So if you, although I apply the distractor for the sagittal, but sometimes we prefer the helmet therapy after the endoscopic suturectomy. So for the details, I can make a presentation later.
Okay, and we also have another question asking, would the head asymmetry condition, like if you treat the head asymmetry condition, would that also gradually affect the facial asymmetry treatment as well?
So can you ask again?
Okay, so I think the question is asking, when you treat the head asymmetry condition, then like as a result, the facial asymmetry condition be treated as well?
Yeah, so actually for the adult patients, the cranial distraction would be really not a good indication, I think. So, but although I have some experience, there's the same one-piece osteotome in adult patients, and when the osteogenesis is not that good compared to the infant. So overall, the contour is okay, but bony regeneration really require longer period of time. So so for the other patients, actually, it's a symmetry of the maxilla and mandible would be more ideal. And then for the infants, actually, I'm really trying to minimize any kinds of facial asymmetry based on the observation of endocranial morphology after the distraction.
And also we have a question from Dr. Jordan Steinberg asking, do you elevate the temporalis muscle with the scalp flap?
It depends on the situation. So, but temporalis sometimes should be elevated because of the making a hole on the temporal, the terion area, but the complete elevation would not be necessary in all cases. So we are trying to minimize the temporalis, the elevation and detachment.
And I think that is currently all the questions that we have from the audience. Does anyone have any more questions that they want to ask Professor Choi?
Okay. If no more questions for Professor Choi, actually, I would like to pay again for my deepest gratitude for Professor Choi for today's wonderful presentation for our audience in ICC. Thank you. And Professor Choi has a lot more very abundant information want to tell us in the future webinar, right, Professor Choi? As you told me. Yeah. So
I'd like to visit Taiwan in person.
we would like to visit Korea for your Asan Medical Center as well. Yeah, but it's a difficult time now, pandemic.
Yeah.
Yeah, Dr. Choi, you should be invited to visit us again sometime in the future.
Yeah, you should.
Yeah, just come.
You should come Korea. Peng Yun and Dr. Lu and Dr. Junior.
Okay, thank you. So now I would like to have a very valuable photo, a group of photo for our audience in ICC now. Okay, so I invited all our audience to show your face and open the screen. Yes, I need your smile. Thank you very much. We have a very good opportunity to have photo with Professor Choi. So thank you, Dr. Jordan, Dr. Jichin. Yeah, so I would like to count to 3 and please give me a smile. Okay, 1, 2, cheese. Thank you very much. Okay, so I would like to conclude today's webinar. Yeah, thank you, Professor Choi. And thank you for all the audience today to be with us in the whole 1 hour times in ICC. And we'd like to invite you for our next, the coming webinar in December 19th. The presentation will be given by Dr. Sugawara in Japan. So thank you for your participation, and good day, good night, and good morning. See you next time. Thank you, Professor Choi. Thank
Bye.
you.
Thank
Bye-bye.
감사합니다.
감사합니다. Thank you, Dr. Werner.
Yeah.